Thank you. This is Dwayne Poole. I'm the chair of the North Dakota State Health Council. We're going to call the Wednesday, August 12th Health Council meeting to order. And the first item is to address the agenda. Are there any proposed changes to the agenda? Hearing none, we'll start with item 1 on the agenda. If at some point somebody's not available for an item that's in order on the agenda, we'll bring somebody else up to fill in until that person's able to join us. So for now, let's review the minutes from the May 13th meeting. And are there any changes or discussion items associated with those minutes?
We'll be having some follow-up on the updates that the state health officer gave us last month. I'm particularly concerned about the some of the funding in the lawsuit. Otherwise, I move that we approve the minutes.
Second that we approve the minutes. Jim Brusso here.
Okay, we have a motion by Dennis, a second by Jim to approve the minutes. Those in favor signify by saying, or let's do a roll call vote since people are online and can't tell who's who.
Birch? Russo?
Yes.
Dietzman? Fedorchak? Lanoy? Poole?
Yes.
Roars?
Yes.
Saylor?
Yes.
And Wolf?
Yes.
All right. So the minutes are entered into the record. With regard to any legal proceedings, we would probably want to go into executive session if there's any sort of an update on those. And I don't see us having one at this point in time. I don't think we've moved forward far enough to, or that there's any significant new news on those. Tara, is that accurate?
Which legal proceedings are you discussing?
Dr. Wolf, which one were you asking about?
What? I'm sorry.
Legal proceedings.
I didn't get that at all. I'm sorry.
Let's not worry about it unless Dr. Wolf has a specific question.
Okay. Sorry about that.
That's all right. Second thing on the agenda is Kirby Kruger from Disease Control. Kirby has an update on the COVID-19 crises. Welcome, Kirby.
All right. Can you hear me all right?
Yep.
Okay, fantastic. Thank you. So yeah, I'm going to give you a little bit of an overview of the whole section. I just want to briefly mention in the Forensic Examiner's Office that Dr. Barry Miller started as the State Forensic Examiner July 1st, and she's getting settled into her position. Dr. Mazzello continues to do some mentoring with her as needed. And then the other part I'll just mention real quickly in the Forensic Examiner's Office is that we had a meeting with UND on the needs to extend that contract. As you know, that the UND Department of Pathology with the School of Medicine up there, we have a contract with them for them to cover 21 of the eastern counties for forensic services. And so we just met with them, and I'll be putting together an optional budget package for that to extend that contract as well. So in disease control, I think from our perspective, what we've been doing is we've been busy hiring, and we are working to increase our capacity to do case investigations and to do contact tracing. And so right now we have people at the state level, 52 full-time or part-time case workers that have been brought on board. We have 10 full-time or part-time case managers that are assisting with managing those caseworkers. And then we have, although some of the local health departments have switched their priorities from contact tracing to assisting with testing and then helping their local schools prepare for opening and providing guidance to schools. Some of them are continuing to do some contact tracing, and specifically Fargo-Cass Public Health and Grand Forks Public Health both have a fairly good contingency of public health workers that are helping with contact tracing yet. We have contracts with NDSU and UND for graduate students and pharmacy students, and I think some nursing students to help out with contact tracing. And they are both increasing their capacity for contact tracing. We extended our increased their contracts for that so that they could hire more individuals. One of the things that I'll mention real quickly is that we had the Quality Health Associates on contract to help with contact tracing. That contract expired. They elected not to renew it. And so we did lose some contact tracers there. We are continuing to hire. We had last week, we offered 47 positions for contact tracing. This morning, I got a report that 40 of those individuals have accepted. So we're hoping to be bringing those individuals on, and we're continuing to advertise as well there. So. In addition to the contact tracers, we have hired a COVID program manager. Her name is Abby Folson. Abby is working out of Grand Forks, and she has a graduate degree in public health from UND, and she had been working at Altru up in Grand Forks and was interested in getting involved with COVID. So Abby joined our team as our COVID program manager. She has been helping us out with getting contracts in place, with overseeing our contact tracing programs, and helping with getting other hires in place as well. We are looking for subject matter experts in 4 main areas to join our team. That includes businesses, pre-K through 12 schools, universities, and daycares, actually 5 areas, and then travel. The travel one, it doesn't seem like it would be all that complicated, but it does involve a little bit of work, because part of what we need is somebody who can work with the Centers for Disease Control's division of quarantine. And when we have people who are flying on airlines and we find out that there may be exposures on airlines, we need to reach out to the Division of Global Migration and Quarantine at CDC to provide that flight information so that they can do additional contact tracing. And travel is starting to increase again, and so we're starting to see more of these. And it does take time to make those contacts with the CDC on that. So we have right now we have 7 healthcare associated infection coaches that are helping with long-term care and acute care settings, and also group homes. This is Faye Salzer and her group. We had 1 individual that resigned, and her last day will be this week. We are hoping to hire another 2 or 3 individuals in that area. That group is working a lot of long hours, and they work evenings, they work weekends, and they make themselves available whenever the facilities who have cases or have concerns need assistance. They really do try to make themselves available when that assistance is needed. And so we're looking to get some more people on that team so that they don't have to work the long hours that they are working. I'm afraid we're going to burn these individuals out. We really do need to improve that team. No.
Jeremy, can you mute?
we're working on hiring individuals to help us with data quality. We have 2 data systems currently that we primarily use. One is our electronic disease surveillance system, MAVEN, and the other.
I'm sorry. Somebody has some serious noise in the background. If you're not speaking, would you please mute?
Jenny, I believe that's yours that's picking up some noise.
Oh, sorry about that. Sorry, I had some difficulties getting connected this morning too, so sorry I'm late. Okay.
So there are 2 main data systems that we're using. The one is the MAVEN system, which is our electronic disease surveillance system that we've had in place for about 12 years now. The other one is Microsoft's Dynamics 365. That system was brought on board just this year in March to help us with the contact tracing. The MAVEN product it's not easy to link cases and contacts together in MAVEN. So we looked to ITD and they had recommended the Dynamics product here. And so there's a lot of work that's being done on that to collect the data that we need to collect. We've been using it, but there's been a lot of changes that have occurred since we first started using it back in March, and those changes continue. The most recent push now is being able to collect information regarding the reopening of schools and what schools, collecting data on what schools and the specifics for those schools. That includes universities as well. So there's a big push to get those upgrades implemented before college and school starts. And we're running out of time on that, but North Dakota IT is working hard to get that done as quickly as possible. So currently we are monitoring or tracking about 5,000 contacts. As that's a dynamic number. People drop out of the contact tracing when they reach that 14-day period from their last exposure. And so that number decreases when they drop out, and then it increases when they come in. But right now it's about 5,000, a little under 5,000 this morning when I looked at the numbers. And so we do need a lot of contact tracers. Once we get our lab up to the capacity that we really want to have them at, right now they're pretty consistently running about 4,000 tests a day. They have a capacity that's somewhere close to that 6,000 mark. When everything is running perfectly, when they have staffing, when they have all the lab supplies they need, when all the instruments are running perfectly, my understanding is that their capacity is right around that 6,000 mark, and on their platforms. But they're pretty consistently going around 4,000 right now a day. So, but when they get up to that point where they're around 8,000 or so a day, that's sort of doubling the capacity, and we're going to need to make sure we have the contact tracers in place to be able to support that type of testing. And so that's what we're working on, why we're continuing to hire those caseworkers and contact tracers. So we had some issues, just along the lines of the contact tracing. We had some issues with making sure we had good coverage over weekends. We took a step back, looked at that. We offered some pay differentials for weekend coverage, which made a difference. It helped that we were hiring more people, and more people were available. But I think the weekend differentials in the pay helped us to encourage people to make themselves available for weekend coverage. And in the last several weeks, we've been able to cover weekends fairly well. And so that's been a step in the right direction. So. A little bit about vaccine. Even as we're speaking right now, we have a team from CDC and an individual from the Department of Defense that's in Bismarck meeting with us. That meeting is regarding COVID-19 vaccine planning. It's for planning for vaccination. It doesn't have anything to do with clinical trials or anything like that. It's just simply a planning meeting. North Dakota was one of several states that was selected to receive a visit from CDC. primarily, they chose us because we do have a good working relationship with the CDC with our immunization program. The other reason is they were interested in coming to a rural area, but also interested in engaging our tribal nations in the planning process as well. And so I think those were the three primary reasons why North Dakota was chosen. It's been a good meeting yesterday. We spent a lot of time talking about the ins and outs, the assumptions. There are three leading candidate vaccines that are going through the vaccine trials yet. Nothing has been finalized, but there is one candidate vaccine that is in phase 3 right now. So we're not sure exactly when vaccine will be available, but CDC is telling us we should plan for vaccines as early as fall, and with sufficient numbers maybe later in the winter. Although a lot of this is still, unknown. I think there's some assumptions that they told us that we can start planning around, and I think one of and this is not unusual because when H1N1 unrolled and the vaccine unrolled in 2009, it was very similar. But I think one of the assumptions is that a vaccine will be limited at first, and when it first starts coming out, there will be limited quantities. I think that the other assumption they told us to look is that there would probably be central distribution from the federal level in quantities of 100 or 200, 300, whatever. But if areas that needed smaller quantities or were only going to receive smaller quantities, then those smaller, we would get the quantity at the state level, and we'd have to break it out and make sure it gets sent out. So I think those were a couple of the assumptions that they asked us to look at. ACIP, the Advisory Committee on Immunization Practices, will be meeting. They'll be talking about priority groups, and we'll take our direction from that on how we define priorities for those initial doses as they get released. So there's a little bit of planning that will have to occur around that as well. So, I think it was a very productive meeting yesterday, and hopefully this morning's meetings goes as well. I'm not there, obviously, because I'm with you today, but I do plan to join that meeting this morning a little later. So, I think that's pretty much everything I wanted to cover. It's been a busy summer, and the summer has gone awfully fast. We've been able to prepare some guidance for schools, for athletics, and for the performing arts. Kim Mertz and the Healthy and Safe Communities section, they've really stepped up to the plate to help with planning for the schools. They've been working with DPI. And so we really appreciate that assistance from the Healthy and Safe Communities section on that. And I think the other part of this is that, the partnership with the North Dakota University system and making sure that we're coordinating on the contact tracing that has to occur for those systems when we get students. We've been working with, I think that the relationship we have with them will help enable us to better communicate when we do have cases that occur on the university level, and how we get those individuals notified and get the contacts notified. So.
Kirby, Jim Russo here. I have a question for you. Can you hear me okay?
I can hear you fine, Dr. Brusso.
Well, first of all, I'd just like to say you guys have done a fabulous job. This all happened so fast, it just dumped on you, and you get all kinds of criticism. I know I'll probably never get enough compliments about all the hard work you're doing. I was just wondering, Are you getting pretty good cooperation in the contact tracing? Are people cooperating with contact tracers?
Um, we have anecdotal information from our contact tracers that, they are running into more resistance. But it's not overwhelming. Most people are still interested in cooperating. But we run into a few that they don't believe their test results they're not symptomatic, and so they don't think it's an issue. We are providing, the education on why it's important that they comply with our with our ask for them to quarantine or isolate. But like I said, for the most part, especially those individuals who test positive, they have been fairly cooperative. I think one of the challenges, Dr. Brusso, that we have is with the contacts is, if they're adult and they're working, there's a high likelihood that they're working in some critical infrastructure. And so they're going back to work as contacts. Now, our guidance for them is that they're still under quarantine. They can go to work and then they have to go home, and they shouldn't be doing anything outside of those two activities, either be at home or be at work. And they should be wearing masks. Their employer should be screening for symptoms on a daily basis in those situations. But that's been a challenge. These individuals, regardless if they're construction or a healthcare worker, or they're working in the food industry somewhere, they fall into that critical infrastructure, and many of them are electing to go to work because they need the paycheck. So, yeah.
And that I was also thinking that the instructions and recommendations and so forth that have come out of the CDC and elsewhere have been confusing at times. I was wondering if the people who test positive are getting given written instructions on what they should be doing. I think there's confusion over even things like the terms quarantine versus isolation. And it seems to me like they should be getting some written information so they have something to refer to.
Yeah. For the individuals who test positive, we do monitor them, and they do get sent a fact sheet on what it means to what they need to be doing. And for those who are in quarantine that have emails, that we do send the fact sheet as well to them. So they are getting some written documentation on what they should be doing, as well.
Providers who don't really follow a protocol when they find a positive case. And it seems to me there should be some standardization on how people are approaching the positives, and probably would go for the contact tracers too, or the contacts, I should say.
And that has been a challenge because I think our contact tracers have mentioned this, that sometimes there is conflicting information coming from what the provider is indicating needs to be done and what we're telling them to do, and then that causes confusion. And you're right, Dr. Brusso. So.
Our county recently had 19 on one day, 11 on another, and then yesterday was 28. How can you track that many people in a small county? Or how do you do it?
So I can sort of outline the process, and when we get notified of a positive, we have electronic laboratory reporting, and I'll tell you that we are hooked up now with all of the major labs electronically, so that's good. We have electronic laboratory reporting for COVID-19 testing. We get results both on positive and negatives. It's not just the positives, but when a positive comes in, that goes out to our regional field deputies and to our regional case managers. And the case manager who's on duty will look at those and will assign those cases out to individuals to be investigated. So it gets assigned through the Dynamics software that we talked about. That gets assigned to a caseworker. The caseworker initiates the conversation with the case, does the investigation, identifies the contacts, gets the contact information for the contacts, And then right now, the model that we're using is that same caseworker then is responsible for notifying contacts. And so then they reach out and they do the contact notification. The cases are monitored on a daily basis electronically through email or text. The contacts are monitored through an automatic email that goes out through a survey process. So every day a survey goes out to their email, and that just gets generated automatically, and then they just respond to the survey. It's a very short survey asking if they develop symptoms, if they're running a fever, that type of thing. And they just reply to that survey on a daily basis. And so that's how we do the monitoring for the contacts and the cases. So it becomes a sort of a passive system after that initial investigation and that initial notification. It becomes a little bit more passive at that point in time. We provide information on when their isolation can end or when their quarantine can end. Isolation is a little bit tricky because you have to. It's a 10-day minimum isolation. If they're symptomatic, then you need to also have a period where they have no fever for 24 hours and their other symptoms improving before you can release them from their isolation. For contacts, if you have a definite date of the last exposure, it makes it easier. But if you're a household contact to a case, it becomes a little more confusing because your exposure is ongoing and your last day of exposure is that last person's day of infectiousness. So that 14-day period that we usually think about for quarantine then gets extended quite a bit, and it can be quite a bit depending on how that situation unravels. And so the contact tracing for household contacts is a little more involved because we need to first determine when the case is non-infectious, and then we can start advising how long the quarantine will last after that. So.
Thank you.
Dwayne, you're on mute, I think, if you're asking a question.
Yes, I was asking if anybody else had questions for Kirby. If not, I'll ask one, but I want to make sure the council has the opportunity first.
Well, again, as Dr. Brousseau talked about, this is Daryl, and sorry for being late. I was there. I was seeing you. I just didn't follow instruction very well from Pamela on how to connect. So I'm here now. But Kirby, as Dr. Brousseau said, thank you for the work you're doing. It can be thankless at times and certainly tiring. I hope you found a way to sleep at night. As you know, that there are times when the validity of the testing is questioned, and I'm wondering, is there any work that's being done to do QAs on the different analyzers and et cetera? Certainly, we don't want to have anybody think that there are false positives because that just leads to more potential spread of disease. But I'm just wondering internally what you guys are doing.
Yeah, every run has a QA component. There's positive and negative controls that are done with every run. And so, we have 1, 2, 3, 4 different platforms that we're using on a regular basis. So we have the Abbott, the Hologic, and the Thermo Fisher, and then we do some work on the Cepheid. It's pretty limited because that's not high throughput, but at least on all of them, they have the positive and negative controls that are run. They look at the cutoffs for the cycle times, and so what I've noticed in the last month or so, month and a half, is that they are reporting out more indeterminates from the lab, and so if they're not sure, I think that they're doing a good job. If that run isn't clean or that specimen isn't real clean on being positive or negative, they are calling it an indeterminate. And so I think they're doing the quality things that they need to do at the lab. The PCR testing that we run at our lab, all 3 of those platforms are good platforms. I think the issue is there anything better out there? I'm not sure there is anything better out there. We're running the best test that's available. It's a good test. It's a PCR test and very specific, looking at very specific segments of RNA. So the number of false positives should really be minimal. But having said that, anybody with a laboratory background or a public health background knows that when you take even a good test and you apply it and you start testing, tens of thousands of people, there's going to be some false results in there. But how do you determine which one's false and which one is not? It makes it difficult. And so the testing that we do, I think, is really good. And we understand that there are some concerns out there with some of the results, but I don't know if there's a better alternative right now, to be honest with you. So, and I'll let Dr. Stahl weigh in on that if I've misspoke on anything. So.
Right. There is, it is the gold standard at this point in time. There is no alternative at this point in juncture to have a test that's going to be better than what we have now. There might be new ones as they come out, but looking at the process as to how we approach it, we have two controls that internal controls and external controls that we have when we validate these tests on a specific run. We're also one of the only public health labs in the nation that has sequenced genomes on this virus. And when we look at cycle number off of the Abbott M2000 platforms, or we look at cycle threshold numbers off of the Thermo Fishers or Hologic Panther systems, one of our checks that we always do on a periodic basis is the sequencing of the genome. We've done that. And when we have ones that just barely cross over the threshold, we've looked at the sequences of those as well. We've been able to sequence those genomes. So it tells me that although there's questions about false positives, it's extremely rare, and in almost all cases as to which we found has been a clerical error or a LIMS reporting issue rather than has been an issue with the machine itself.
And then I have a follow-up question. I guess working in healthcare, one of the things that we hear the most about right now, and then yesterday at a meeting, legislative meeting, I think the concern that I hear the most often is actually just the throughput rather than the validity of the test. So can you give us an update on throughput and timelines?
Yeah, I think the throughput, as I described, we're running about 4,000 a day. That's sort of been about the average, just from the top of my head. I know that our capacity is a little higher than that, and there have been some issues with turnaround time and getting results out. But I think at this point in time, once the specimen arrives in the laboratory, usually they can get that processed within 24 hours. And that's sort of been the norm. Now, sometimes there's exceptions. If a machine goes down, then that causes some problems and some backlogs. But for the most part, once that specimen arrives, they can get it processed and get a result within 24 hours or so. Having said that, I think that from our perspective, we still need to try to improve the whole process from the moment that these individuals are getting in line to get a specimen collected to the moment they get their results. And so what we've been really focusing on is what happens once the lab gets that resulted, how can we turn those results back to the person and get them informed, or back to the providers and get them informed as fast as possible. So.
Right. There's one aspect that I'll also mention, Kirby, is that the lab portion of it is actually very good. The transportation time does take account to a certain component of it as well. We do run labs from hospital systems, and they might not necessarily report those results, but then we're asked about those results. And it's the assumption that it's the Department of Health that has done it, but really it's the ordering hospital or an individual from a hospital that has ordered the results. And then it's DOH is asked to follow it up when it's actually not something that we report all the time in that regard, because it was an ordering provider physician from one of the major hospital systems in the state. that's been kind of a question that we're trying to work through to help message to the hospital systems that if you order it, it's your responsibility. You have to own the test.
So when hospital systems order tests through our labs, do they bill patients, or do we have cost recovery as a lab? Is that covered by the federal funding? Is there an issue involved in that in the use of state resources for the private sector? That's an honest just question.
Yeah, that's a good question. The approach that we've taken with it from our side of it is that, one, we haven't looked into it. We do know that we do run tests from hospital systems, but we feel that it's oftentimes a case of, diagnostic tests for patients, for ICU care, emergency care, that sort of thing. I don't know if they bill or not. I have not asked or looked into that. We feel the responsibility that we need to get the test resulted to them. But that's a good question.
I could see a being able to charge and that sort of thing, but then charging for the actual testing when Kirby's program is covering the cost would bother me as a citizen representative of this council.
So I'll just bring a rural perspective from our facilities, both our federally qualified health center and our hospital here in Beulah Hazen. What we do is the swabbing, and then we send this test to the state. We don't charge for any of the lab draw or sending that specimen off. What we may bill for is if that patient comes in, has a clinic visit to determine what's happening with that patient. We do bill for that. Just that's what
that protocol makes sense then. So I was just curious, just because I'm supposed to have the citizen's hat on as I sit here in some circumstances, so I figured I had to ask that question. Kirby, this is back to, I have a couple questions over a few things that you'd mentioned. When you talked about going from the 4,000 to 8,000, you said that there might be need for more contact tracers, that sort of thing, which then prompts the question, me being a biometrician type, is are we at the point yet where we have enough testing to understand some of the population level estimates, as in being able to break down an estimate of known positives versus unknown positives in the population?
Yeah, that's a good question, and I'm not sure if I have a good answer for you on that this morning, Dwayne. I can tell you that when we are able to do some focus testing, go into a closed setting, that really is helpful in understanding what's happening in the setting. The population estimates, I think that we've done a pretty good job of testing, but I don't know. I think this would be a better question for our health analytics team. So to be honest with you, I think that they may be better qualified to provide some information on this. But I can let Dr. Stahl weigh in as well. Data has never been my strong point, Dwayne. I'll be the first to admit it. I'm in the division of. I know the importance of it, and I know why we need to collect it. And I make sure that I work hard to make sure we get the data that we need collected. But the analysis of it is not my strong point, and I'll be the first to admit it. So, yeah, Dr. Stahl, do you have anything more you want to add with that?
Yeah, one of the things that we've realized is that we're data heavy, research poor. One of the components that we're working on trying to as we address this pandemic is a department within the Department of Health that would be a health analytics department that we've developed to help assess this information on a more real-time basis so that we can have better answers for these sorts of things, but also an outreach with our university systems on a more regular basis to make sure that we have we're making the right decisions for our population as we move forward.
Yeah, that seems to me like it's real important to have known positives and deal with them from a community spread point of view, and that has to be first and primary in the priority of why we're doing some of this stuff. But at some point, you also need to, I think, from like the governor's and Kristen's perspective, is you kind of have to at some point understand the population implications and are you doing enough? Is what you're doing working? And I think that comes from those population type estimates.
Right. I think you hit the nail right on the head there.
All right, and then my next one was basically a little bit of a pat on the back, and that was that immunization update with the CDC came out a couple of days ago, and then it seems like immediately you guys came out with a clarification, which I thought was really good, in that no, this is not testing the drug on our population. It's about the systems for dispersing it and getting it to those who need to be prioritized for it. And I want to say that I appreciate the clarification that came out as quickly as it did.
You know, and it's just an example of, you know, several of us looked at that information before it went out, and we weren't exactly, you know, for I guess for all of us, because we knew exactly what the meetings were about. What we put out to the public seemed to make sense to us, but it's just an example of once it gets out into the public how things can be interpreted, and yeah, it was interesting. So
the life of a PIO. And then my third question was over, and this might be just because I have too much anecdotal information, changing symptomology from earlier in the tracing process with this particular virus. So my question is there a change in symptomology, and is it based on any sort of demography that we know? Is understanding changes in what symptoms different populations are having, or how the symptomology itself is changing, whether that needs to be something that we address with the public so that they understand that it's not what we heard 3 months ago or 4 months ago, that we actually have different insights into symptomology at different age groups or different demographic groups. And then the follow-up to that would be, since you're doing genomic sequencing, is that symptomology changing with the virus?
yeah, and the latter one, I don't know if I can answer that one at this point in time, but I can tell you that in terms of the first part of your question, you know, as we take a look at the data, you know, we still continue to have about that 30% mark for individuals who are asymptomatic. In overall, we're somewhere in that area. I think what's emerging is that younger children do have a tendency to have milder symptoms or be more asymptomatic, and then I think by the time you get into adolescence, then you start seeing individuals more likely to develop symptoms. That range of symptoms has been fairly consistent. I think in the last couple of months, you know, diarrhea and nausea and vomiting sort of have been added into this component, and shouldn't be dismissed as being related to something else, because I think they're finding that individuals with COVID-19 infections can display the diarrhea, nausea, and vomiting as well. You know, and I think what emerged as well, and this emerged relatively early, but I think is interesting, is the altered or the lost sense of taste or smell that occurs with this, and so I think those were rather interesting things that emerged out of this as well. So.
Yeah, I heard a fair amount about just, all I had was a simple headache, so I kept going to work, or it just seemed like seasonal allergies to me, so I kept going to work. And people aren't necessarily putting one and one together. And so my question then is, and then this is probably for Dr. Stahl as much as for you, is does there need to be some public outreach to make sure that that range of symptoms is reinforced, so that when you're sick, stay home?
We're trying, you know, and I think we've tried to message that to the public, and we've tried to message that these symptoms may be very mild, but I think you're absolutely right, Dwayne, that what happens is, you know, well, the headache isn't all that bad, or my sore throat isn't all that bad. This could be my allergies, and so I'm just going to do what I need to do, and yeah.
Yeah, and I think one of the additional challenges, like Herbie was talking about earlier, is it's often in those populations where people need to go to work, whether it's due to their job itself or due to the financial situation. And so it's very difficult when it's such a vague symptom like that to justify the PTO day or the day without pay, or just not being able, for me, working in a hospital, well, there were no days off or working from home. So I think that's the difficulty with those, especially the vagueness of the symptoms.
Right. Those are all excellent points. And I would say that, really the best way to look at that is to message the fact that we're getting some pretty good data about masks now. And when we have these, runny noses and stuff like that, and you have to go to work and you have to be there, and it might be the scenario where wearing a mask is the right thing to do for not only yourself, but for the public good.
Question from Bruce here. We've been talking a lot about epidemiology. We have a state epidemiologist involved to some extent in the process.
Yeah, Tracy Miller she's been working very closely with the data analytics group. Yeah, and so she's been heavily involved with a lot of the data. So.
All right. Are there any other questions for Kirby or Dr. Stahl over the medical services section? I'd like to echo what the rest of the council has said, and that is you've done a yeoman's task here. It's a lot of heavy lifting, a lot of throughput, a lot of scaling your operation in a very short period of time. And I'm sure you get more darts than you do bouquets. So thank you. We appreciate it.
Well, I appreciate being able to come in today and provide a report to you, and I appreciate the support. It makes a difference. Trust me.
All right, then we'll move on if Tara is available.
Yep, I'm here.
All right. We'll move on to roles and responsibilities of the Health Council. One of the reasons why I asked Tara to speak is because historically, prior to Tara, Ed had been our Assistant Attorney General, and anytime there were changes in the State Health Council, he would schedule time to come in and basically address the entire Health Council on here's what your roles and responsibilities are, here's the processes that you should be involved in. And so it's basically one of the educational sessions for the new members and complete reminders for those of us who had already been there in terms of, this is the hat you wear when you're at the Health Council, and here's your roles, responsibilities, and authorities. And it basically provides that framework so that we know how we can work as a state health council to support the people of North Dakota, the legislature, and the governor's office in those roles, and can help develop those relationships with the health officer and others to make sure that we are doing whatever our legislated responsibilities are. And so as chair, since it's been a while since this has happened, I want to make sure that what I'm doing as your chair and what we're doing as a council is meeting those expectations, and that we also have the opportunity with Dr. Stahl and others to basically figure out, okay, how are we going to make this work best for those who we serve? And that's kind of where this came from.
Yeah, so as Chairman Poole said, I am the Assistant Attorney General assigned to represent the Health Department. I have a number of different entities that I provide representation to, including the Department of Labor, the Department of Commerce, the Information Technology Department, and then a laundry list of boards and entities. So my role as the health department primarily in the past has dealt with the state health officer and the division, the health council generally. I have been involved when you've needed me, but to that extent, the health council has sort of reached out when they needed assistance. So one of the things that I kind of want to talk about is, just because there are new members, is to make sure you understand your roles and your responsibilities. So the Health Council is essentially an entity that's created by statute. The statute says that there will be 9 members of the Health Council. 4 will come from industry, and 5 will come from and represent the public interest. So the goal is to bring people from practice that have that experience and expertise, and then in combination with people who essentially represent the general public. And together, the goal is that whatever decisions you'll make, that they'll be in the best interest of the state of North Dakota. And oftentimes, when the health department and I have a conversation or it's making a decision about something, at the end of the day, what we look at is what decision is in the best interest of health and public safety. And so I would advise you in that same strain or vein to say, okay, when we're making decisions or we're doing things, what is in the best interest of health and public safety? At the end of the day, that's your obligation to the people of North Dakota and to kind of the position that you've taken on. So if you were to go to the statute, Chapter 23 essentially dictates the powers and the duties of the Health Council. So if you've been on the council for, what's the shortest length somebody's been on the council with this group right now?
Would that be Tyler? Pamela, you might have that information.
I'm looking. Since August of 19.
Okay. So has everyone gone through an administrative rules process? So if not, I can so the first thing that the statute delineates or discusses is the requirement that the Health Council have meetings. So at this point in time, you're mandated to have 2 meetings every year. You can have more than that, but you cannot have less than that. 2 regular meetings. If anything would come up, you can always schedule a special meeting. Because you're a state entity, we have essentially what's called the open records and open meeting statutes. That's going to require notice of the meeting so that essentially if the public wants to participate, it has that ability to do so. Thankfully, we have Pamela, who's an expert, and she will provide and do all the notices for you. So that we would just essentially need to know what you want to discuss and what's going to be on the agenda. Because once you have the agenda and you know what's going to happen at the meeting, Pamela has to make that available to the public so they can determine whether or not they want to participate. That's kind of an easy thing that we want to make sure that we don't kind of become negligent about. The next thing that you're kind of in charge of is determining how the council functions. If you want to create groups or committees, you absolutely can do that. The next, probably the most important thing that the Health Council does is the Health Council is in charge of promulgating rules on behalf of the department. So every time the department is looking at promulgating rules, it will come to you and they will say, please review these rules and tell us whether or not you support them, so that we can go forward. So before the department is able to say, go out for public comment and have their rules have the effect of law, go through that process, they have to have the blessing of the Health Council. And so I know in the past there have been questions about when that blessing comes in, and when that process starts from the Health Council. So that's just one thing that we would want to make sure there's an understanding between the department and the council for, because we want to make sure that when the department goes, they either have your blessing or they'll have your blessing on the back end. Does that make sense?
Yeah, thank you.
Yep. So anytime the department is promulgating rules, they're coming through the Health Council. So you'll have to review them. So you'll see rules from medical marijuana to food and lodging to what maybe, I think the recent ones that the health department just did added reportable conditions for disease control. So that would be you. You have that authority for every single division within the department. And so that's quite broad. The other thing that the statute contemplates is the fact that you hold hearings for applicants who've been denied licensure. This one is a little bit different. So the Department of Health is a licensing entity in some respects. In some respects, it is similar to like a board of nursing, because it provides a right to practice or a right to perform certain functions to emergency medical services providers and nurse aides. There may be a few others that I'm not remembering, but so it provides them the right to work and to perform those particular tasks. To the extent that the department would deny a license, you're given the authority to hold a hearing, or to the extent that the department would say, hey, we have these claims, or we've investigated this process against you, and we found out that you EMS provider, you were under the influence while you were at work. That gives rise to a disciplinary proceeding. You, the state health council, would have the authority to hold a hearing. One thing that the department and I have kind of come to the agreement about, and probably is in the best interest of the health council as well, is that instead of holding the hearings itself, we have the ALJ, or the Office of Administrative Hearings, we have them hold that hearing, just because they're experts in that process and of making sure that everything is done in according to the statute 2832. So that's not necessarily something that the health council has been active in, is holding hearings, but to the extent that you would want to, you would have that authority. It would probably be something that I'd advise you against, to be completely honest. And to the extent that the health council has a position on how the health department should be acting or what it should be doing, it has the authority to ask or direct the state health officer to do certain things. That section of statute, I don't know that it's ever been utilized. The one thing that I would say, though, is at the end of the day, both parties have the best interests of public health and safety at mind. And that it would be better to have a united front than to have, interagency fighting, if that makes sense. So as a broad layer, that is, kind of the roles and responsibilities of the health department. The one thing that I would kind of want to talk about really quickly is that as an agent of the state of North Dakota, as a member of the state health council, anytime you're discussing public business, or anytime you're talking about your work as a council member, that is subject to the open meetings and open records statute. So let me give you an example. So let's say Senator Roars goes home tonight and she texts her sister and she says, hey, we had this presentation today. It was about the roles and responsibilities of the state health council. She does it on her personal cell phone, through her personal email. That would still be subject to the open records law if there would be a request for documents related to the health council. So anytime you're talking about public business, it doesn't matter if you're doing it on a personal device or whether or not you're using a personal network. Any of those documents or any of those records, they are subject to mandatory public disclosure if there's a request. So I would just remind you that any of your state business, just to, again, keep in mind that it may be disclosed. So probably we want to keep it on the up and up, if that's the way to say that. Any questions about that? Open records and open meetings usually creates a laundry list of questions.
Jim Bruce, I've got a question for you, Tara. I was just looking at the biennial report that was included in the information we were given. And then in that report, there's the organizational chart, which looks quite familiar. And on that chart, the State Health Council is right up the top, and there's a dotted line leading us to the State Health Officer, almost as if we're whispering in the right ear of the State Health Officer. However, on the new organizational chart, we're a footnote at the bottom of the page. And there have been quite a few other changes, too, to that organizational chart. And I'm not quite sure what that means. Can you explain that?
So to the extent that you're talking about the changes to the org chart, that wouldn't, I think you would have to direct those questions to the health department. I wasn't involved in the reorganization or the the drafting.
Oh, okay. Bring that up with Dr. Stahl then.
We've had to make significant changes in order to respond to this pandemic. In order to be responsive to the citizens as to which we have been asked for, has resulted in us not only having to grow our department temporarily to almost 500 employees from 205, has required us to make significant changes, both from a managerial standpoint, but also to be responsive in the time of need on a day-to-day operation. This council doesn't meet on a regular basis, so we had to make the changes that were necessary to be responsive to our citizenry. That required us to make huge changes within the department, but also grow the department to be responsive as to which we were asked to do.
Oh, it's understandable, totally understandable. However, it is, to me, it looks like a major organizational change, and it's probably something that needs to be discussed at the legislative level eventually.
It likely will be. I can't speak for whether or not this chart will continue on after January 1st, when the legislative session comes back into play. If we have to speak, to needs of the citizenry, I would state that, unless we are able to convince the legislative groups to support us, we'll be back to 205 people and likely not able to respond to the citizens' asks and needs. I suspect that that's a possibility. We're prepared to make that adjustment if we need to.
Well, that's a place where I think you could use the support of people on the State Health Council, because I don't think we're utilized to the full extent that we could be utilized. And if there's an issue that's going to come before the state legislature, then maybe some of us could be of some assistance to you and backing you up on your needs.
Right. And I wouldn't say that, just where the council is placed on the chart it has no implicit message to state that it's devaluing in any way. That's the wrong message. And I would apologize if that was put in that regard.
I'm not paranoid about it, but only thinking that we could be of more assistance to the state health officer and to the personnel in the state health officers under his jurisdiction. And I'd like to say that I think most of us would like to be of more assistance to you in what you're doing. Right now, you're right, we're only meeting 3 or 4 times a year, and there's really no contact with us during the period between those meetings.
Yeah, and I think to some extent, this is Tara. To some extent, I think some of that comes back to the way that the Health Council is laid out is because the Health Council is this entity that requires notice of meetings and all of these other things in responding to a pandemic. I think there's going to have to be a balance, because at the end of the day, and I'm speaking from my experience as well, is that when the show and the department are responding to things on a day-to-day level, those things change every hour. You know what I mean? And so it would be really hard to call it a special meeting to discuss how you're going to handle specific things. So I think if the council wanted to say, hey, here's the broad overarching things that we want to discuss with you, that would be possible. But in order to respond, the department's going to have some flexibility. Does that?
Well, I don't think you find a lot of opposition to what you're doing. In fact, I think you'd find a lot of support for what you're doing. But I'm saying is that I think we could be utilized in a supportive way with you during the year, and maybe especially during the legislative session. So I'm just offering to help.
Yeah, and I think we've had a little bit of conversation
to try to figure out how to do this better so that we can work together on this. And I don't know. And I think it's going to have to be a collaborative effort between myself, Dirk, members of the department, because sometimes I suffer from the tyranny of urgency and have to, it's been very long days.
Oh,
I think as Tara was talking about the open records laws, that also creates that extra layer of complexity to involving us.
Right.
Because, I know in the past we've said, hey, can we do this by email? But we can't, because that has to be noticed and available to the public and all of those things. So I think that there are some things that, I think the Department of Health would love to get our input on or involve us in the decision-making process. And yet those laws really narrow the ability of the department to utilize us to a scope that, in a private industry would not be a problem.
So maybe just to provide another perspective, certainly our role is not operations. That's the health department. And certainly Dr. Stahl is assumed this midstream or 2/3 of the way through this whole pandemic. But I'm also of the opinion that the Health Council, if in fact its role is to do what's in the best interest of the population, of the citizenry, then we should be providing some of that input to the health department, not necessarily day in, day out, but I don't think that there's any of us that wouldn't be willing to participate in more meetings to just provide some consumer input or some additional thoughts to the health department as they're then navigating all of these. I kind of feel like Dr. Brousseau that maybe we haven't been involved as much. Maybe that's our fault. Maybe we should be initiating that, or maybe it's just been too busy that reaching out to the Health Council hasn't been a priority. But anyway, hopefully we could provide some input, and that would be valuable to both the health department, the governor, etc.
I was just going to echo that to Daryl. We are not part of the day-to-day operations, and we have the faith in Dr. Stahl and his team to be able to handle those types of situations and issues. And things are changing very rapidly, and it wouldn't be prudent for us to have to be dealing with those types of areas. But we have a number of experts and people that would be very willing on the Health Council to be able to provide input, whether that's on a policy area or being more strategic in helping you make those bigger decisions for the department. I do kind of feel that I've been on the Health Council, I think now for 8 years, and I do feel we did have more involvement in the past, and we want to be able to provide that value, I think, to the health department, and I feel that has probably been lacking a little bit in the past couple of years, and just to know and maybe to reassure you, Dr. Stahl, as well as your team, that we are here for you. We are here to help in the, maybe bigger decisions and the more strategic decisions in helping moving the health department forward and keeping in the mind of our, health and safety of the citizens. But I know the open records, open meetings type things, there are some issues that, we have to follow the rules. But maybe just to reiterate to you and your team that we are here and we do want to provide value where it's needed.
Right. Thank you.
Well, I think I'm hearing some consistencies here, and that is that the Health Council is not looking to usurp any authorities or anything like that. It's more about being a resource and where, as a department and the governor's office and the legislature kind of give any sort of feedback that if there's a strategy in which the Health Council can serve a greater role, and then there's the time to bring them in and that role can be served best from their perspective, that we should be engaged. The other thing that I think has come up at several times is feeling like there's a lack of information coming to the Health Council, not on controlling the day-to-day operations, but just being informed of things on a more regular basis other than just the basic PIO reports. I don't know whether that creates issues with the open records issues or not. If there's additional communication going out, I lean on Tara for that. But I think that what we're hearing here, and with my experience with Dr. Stahl, and he's been very good and very open and upfront with me, is that there is the willingness to work there and to figure out how to make this relationship work and how to make it work as a board that has limits on it, but as a board that has the ability to get the authorities to get some things done, that there might be some opportunities there for us to look at how we engage more strategically in the future with them. But that it's their department. They run their department. We're advisory and governance within the framework of what that Chapter 23 identifies.
comment. We now have a health strategist for the state too, and I don't see that person's on the organizational chart. And I wonder how he interacts with our state health officer and what his relationship is with the state health council.
So the chief health strategist position was created by the governor's office in really a way of looking at how do we make public health better and how do we make citizens of North Dakota healthier. It is not part of the Department of Health. It is an advisory position to the governor's office regarding the Department of Health. And that is, by and large, the limits of my understanding of it. They do work with multiple public health leaders throughout the world to look at ways to provide recommendations on how we can do better for the state of North Dakota as we look at approaching the next legislative session. But that therein lies the limitations.
Well, just once again, then I'll say that it sounds like that people on the State Health Council could be of some value to the health strategist also, since we're scattered all over the state and we're kind of maybe listening posts around the state for concerns that citizens have for their health, and especially with the epidemic now. So I'd like to work with the state health strategist too, if there's a role for us there. What do you think?
It's not my call. That's the governor's office call.
Okay.
That's above my pay grade. So.
Yeah, so this is Tara. So from a legal perspective, the Department of Health doesn't have a chief strategist person. That position doesn't exist in the department. That, as Dr. Stahl alluded to, that is totally a governor's office initiative, and that's a position within that office. If you would want to have a conversation with him, we could absolutely reach out and ask for that. But those decisions regarding that process were not from the department.
It just seems a little weird that the health strategist would have nothing to do with the department. Or maybe I'm weird.
No.
I think the idea that the Health Council has been involved historically in the department's strategic planning processes kind of creates a little bit of that, well, wait a minute, disconnect.
Yes, absolutely. Well, and I think one of the new things too is because Dr. Stahl is, new to the department. I think having those conversations about what you want the relationship to look like and how you think, it's functioned well in the past, are definitely now is the right time to have them.
So, would it make sense to you if we do have Dr. Stahl at some point when he's talking to the governor to ask whether or not the health strategist would like to have a subcommittee of the Health Council work with him, so that what he's providing as advice and strategy to the governor also comes then through the advisory council to the health department as well. That way we're all dealing with the same strategy.
Yeah, absolutely. And maybe, an option too would be for the health council to ask that question. Does that make sense? Because essentially, if the goal is for that individual from the governor's office to present or to discuss at the health council, it may be best if that question comes from the health council instead of the state health officer.
Okay.
Dwayne, if I may, I think that would be beneficial to maybe have the strategist be able to do a presentation to the health council during our meetings to have a better understanding, a little more open communication on what their thoughts are, and then how that ties in with the health department.
All right, I'll create a request to the governor's office for the health strategist to provide an update on where that is going. I'm not sure exactly what I'll ask for yet, but I'll reach out to Dr. Broussos. I'll reach out to you to help craft that specific request if the other members are comfortable with that.
I'd be glad to assist you with that.
So, my concern would be the two of you doing it is going to implicate if you're creating a committee, you've now implicated the open meetings law. So every time you two meet, you're going to have to notice it.
That doesn't bother me any.
I've got no secret. So I will, at a time that I schedule a call with you, Dr. Brousseau, I will work with Pamela to announce the call, and we might have to do it on a Teams meeting or something like that. So if somebody decides to log in, they can.
I have one more comment here. You're going to get tired of listening to me, but Dr. Stahl is doing a great job as our health officer, but he's listed as our interim state health officer. I remember when Dr. Wynn was interim president of UND, there was a search committee looking for a permanent president, but I don't think that's going on in the state health department right now, is it? Or what does the term interim really mean now?
So Dr. Stahl is essentially, he's appointed by the governor through Chapter 2832. It discussed how the state health officer is appointed, and he is appointed by the governor. So the health department wouldn't be tasked with finding a new state health officer. Essentially, that would be the governor's office, if that makes sense. So the governor's office would be the one required to create a search committee or decide whether or not Dr. Stahl wants to stay on. That wouldn't come from the health department.
Okay. Sounds good to me.
Sorry, I'm writing notes. All right, is there anything else from the council in regards to Tara's description of our roles and responsibilities?
Tara, did you get through everything you needed to?
I did. One of the things that I would just let you know is in the past, similar to how you're in a new relationship with Dr. Stahl, we're kind of in a new relationship as well because Edward had taken on this part of the Department of Health. While Edward's been retired for quite a while now. It really comes down to, as far as my representation of you, how much do you want me involved? If you would like me to attend your meetings, that's something we can do. But it really becomes, how do you see me helping you? If that makes sense.
Given I have a little more historical perspective, and Dr. Wolf probably does as well, Edward did not attend every meeting. I think that Edward was usually in attendance when there were items that he or the health officer knew were likely to be contentious or might be challenged in the future. Those are the meetings that I think he tended to attend.
I would agree with you, Dwayne. I don't think it would be necessary to have Tara be at each meeting, but I think if there is some legal questions or maybe some, in regards to maybe administrative rules or whatever the case may be, I think it would be more on a case-by-case basis.
Dr. Dwelly did come to almost every meeting, more towards the end of the meeting to give his overview of what's happening within the health department. I think that should continue.
Yeah, Tara, and the other thing that Edward did was when there were litigations that were at specific points or that they were large enough issues that there might be some public questions of it, Edward would give us at the end of the council meetings, we'd go to an executive session. If there was something that needed to be updated with us, he would. If it was no longer needed to be executive session, it was a report out on status of a legal proceeding or the outcome of a legal proceeding, then he would just provide a brief update.
And you have my cell phone number. So if you need me at any point in time, please just feel free to let me know. I'm happy to assist.
Thank you. I'm going to take my prerogative here and basically open this to Dr. Stahl then too, having had Tara's presentation and several of the council members speak up in terms of relationships and interaction and that sort of thing. And I kind of would like to make sure that he knows the floor is open and welcome to him and describing how he wants to work with us as well. I think this is a two-way street.
Yeah, agree.
I appreciate that. Thank you, Dwayne. I mean, as the interim state health officer, I can only speak to my tenure here at this duration, but I would state that I certainly do accept any request, and you'll find I'm probably extremely flexible, willing to work with anyone in order to solve problems or issues, or to take the next best step forward to make sure that we're doing the right thing for the state of North Dakota, and to make sure that we are being representative of all parties. I am certainly open to doing that. So.
Well, your first health council meeting. Welcome on board, Dr. Stahl. We're glad you're here. We're glad you're a resource for the people of North Dakota, and I have to say that I'm happy with some of the things that you've done so far. Though you might be taking darts for parts of them, I think they're in the public interest, and I applaud you for that. So,
thank you.
Anything else over roles and responsibilities, council? Okay, let's thank you very much, Tara. We appreciate your time.
Absolutely. Thank you, everyone.
All right, we will move on to Bobby Will and the primary care office, and included is a update from Dr. Brousseau. Would you like to start it off, Dr. Brousseau, or would Bobby go to start?
I could just start it off, I guess. At our last meeting, we'd had a request from someone who was a podiatrist for the loan forgiveness program. And we discovered that podiatrists were not among those health professions listed to be eligible for that. And I decided we're going to look into this a little bit further. I called Howard Anderson, a former member of the State Health Council, who's been involved for such a long time at many levels. And he said he thought it was probably just an oversight. And he thought that the podiatrists were really considered to be part of the medical team. I contacted the state association to see what their feeling was on this. And of course, they were anxious to be part of the program. They sent me some information about the training of podiatrists. They do go through a very extensive medical training. They take residency programs, so forth. So they're very highly trained. And in personal experience, I'll say that we think of them in the same way we think of orthopedic surgeons or others. They're a very integral part of the team. So after listening to him, I thought it was just an oversight that they weren't included. And if we have to have them listed specifically, I'd be in favor of doing that. I pass some of that information on to Dwayne. I think he's probably given it to Bobby, and I'll turn it over to you to see what you all think about it.
I did not forward.
By definition, in Dickinson, we had a lab, head of the lab who went back to school, became a podiatrist. He eventually ended up with privileges and also was elected as chief of staff. And so I feel they're well trained. However, the original intent of this program was to be able to get more family physicians, nurses, and into the state. And I think we're watering down the whole system. And I think that most of the podiatrists are well trained, at least in more recent years, but I still say they're not physicians any more than a chiropractor is not a physician. So that's my stand. I know it would sound like a conflict of interest. However, I just concerned that we're running out of money to help the original intent.
I think the way it stands right now, that most of the podiatrists work with larger groups, or they're probably working out of communities in North Dakota. So if we're looking to provide assistance to meeting rural needs. I mean, I'm wondering if many of them would qualify anyway, but anyway, my experience has been very good with podiatrists that I know, and I wouldn't have any objections to adding them onto the list.
Out of curiosity, has there been any assessment on debt burden of podiatrists versus physicians?
I think it's pretty much the same because they're in school for 9 years, or training for 9 years, and so something like that.
I think that Dr. Wolf's point in that the program was originally developed for rural medicine, general medicine, getting that out to the rural communities. However, we've expanded the system to include needed or identified gaps in healthcare specialties that might be in the best interest of the citizens in certain areas. I think as the program has developed in that sense, I think that this then falls under, in my mind, if podiatrists are basically considered qualified, then to me it would be part of that evaluation prioritization process in terms of, is this a need in the community in which this person is proposing to practice? And I think it then falls under the prioritization process that Bobby goes under then in ranking them. So if there is a community need for a general practitioner, especially in a rural environment, Bobby, you can tell me if I'm wrong, but I'm guessing that would score higher anyway.
Yes, definitely a primary care provider in a rural area that is needed would, a lot of our podiatry physicians, they would probably be in our larger communities.
Well, and even though they may be in our larger communities, it really looks at the spread of who they're helping. You know, you even look at some of our psychologists and the like, they're normally out of the Fargo, Grand Forks, Bismarck area, but they have a reach all the way to Williston. I guess is they are part of the medical profession, and if they have an opportunity to apply for the loan repayment, I think we could give them that opportunity, and then the chips fall where they may when the rankings get done if they are awarded a loan repayment program.
And based on the needs issue, I would even say that podiatrists serve a very important role in populations where we have diabetes issues, and populations where we have the elderly, especially in long-term care facilities, and if they're available to long-term care facilities that are in some of the more rural settings, I think there could be real value there as well.
Oh, that's a good point, Dwayne, because I think in the Indian communities, 20% of the adults have diabetes, and neuropathy and foot problems are very common among our Native American population. And I think I would see the podiatrist serving that population to a large extent. But I mean, if there isn't if there is not a consensus that this should be added, I suppose it could be investigated further. Maybe we need to consider other aspects of this loan forgiveness program. And
maybe we should see where this goes by just seeing if there's a motion and a second to get the item on the table and find out what kind of consensus or support there is for it.
Okay.
Before we do that, Bobby, have you had inquiries from this field to see if they could be added?
Yeah, I have, and I actually do though from chiropractic and naturopaths every year too. So that's, I just wanted to bring that up. That's something we'd really want to clarify. The states that I have checked into, and as well as the National Health Service Corps, they're very clear on listing an MD or a DO just for that reason, because there is the, physicians that could be depending on the state, but are naturopath or chiropractic or podiatry, and there could be others. Those are the three that do inquire every year with me. But we don't have it listed clear in Century Code that it's MD or DO. So they really could all apply if they're considered a physician. And that is something that I have felt is a little challenging in the 4 years. So I really think no matter what is decided today, we probably really do need to see about exploring having that clarity in Century Code or definitely in our policy, the policy that you guys are in charge of. That is listed in Century Code that you can go ahead and list that in policy.
So physician is not defined in the Century Code either then?
No, it is not.
Kristen, do you have any insights into the legislative intent or where you think your fellow legislators would fall on this?
The legislative intent, no, I don't. That would have predated my tenure in the legislature. I have more experience with this program actually in this committee than in the legislature. I would say just based on the one change we tried to make we did make last session, Bobby, when we updated what was it that we updated? No, I just lost it.
Yeah, we weren't required to do a certain number of dollars each year.
Correct. Yep. So even just trying to change that to allow a little bit more flexibility, but really still maintaining the intent of the program. There was some pushback, and I think part of it was the assumption automatically was that then we were going to ask for more money. And so I think that's one of the challenges with these programs is as we expand the pool of applicants, but we don't expand the actual balance that we're eligible to give out, we run the risk of, constantly kind of diluting the pool. I think as long as we maintain the policy of what is our actual goal here. So as Dr. Wolf talked about, Dr. Brousseau talked about, what is our true goal with this program? Is it rural? Is it family? What are our priorities for the money? Then I guess who's eligible to apply is less important as long as we have a really strong policy statement and direction and we execute that every time. Where if we don't have that good policy statement, we run the risk of it just getting so dilute that we're not reaching the goals of really trying to improve the health in the state.
Thank you, Kristen. From my perspective, I'm not so sure I'm ready for a motion yet then either. I'd almost like to know what clarifying language could be in policy that we should look to satisfy the needs of prioritization for Bobby and also make sure that the larger strategic direction for the program is maintained.
Out of curiosity, if I may ask, is it possible that I could kind of get the notes on this program? I haven't seen it. I don't know what it all consists of, and if I could get some information on it, I would really appreciate
Careful
that.
what you ask for, Bobby. Will get you schooled on everything.
Well, and maybe just throw out there, maybe throw out there as well too. Bobby's the one who interacts the most with folks. Maybe she could, based on what her experiences have been and what she has sensed for the need, that she could come up with some thoughts and ideas that we could consider in the future on how some of this policy might be able to be changed.
I think that's a good idea, Daryl, and having her work with staff and Dr. Stahl's office specifically, and to make sure that we're still meeting that intent. And then Dr. Brousseau, if you'd be willing to be sort of the health council voice in that discussion, since you've studied the issue.
So that idea is a very good one to maybe have Bobby look into it, have Dr. Stahl look into it, and then I could send some of the information about the training of podiatrists and so forth. But as far as the goals of the program, I think that's very important. I'm sure it was started to try to get more people out into our rural communities, and we really have to keep that in the forefront. I agree with what Kristen said there. That's got to be our number one priority. So yeah, I'll do whatever I'm asked to do.
Is that comfortable with you, Dr. Stahl?
Absolutely. Absolutely. Yep.
All right. Let's go to Bobby then.
Okay. So if we are going to go ahead and look at the defaults for the state loan repayment first, the first one listed, it is just an information that we've lost Leah McKenzie from the state hospital for being terminated in June. And then the next one would be Dr. Shaw. She does have a letter, so hopefully you guys all have the opportunity to read of her change from Devil's Lake over to Grafton. And so she has asked you if you would consider allowing her to amend her contract and stay in the loan repayment program. Do any of you have any questions? I have talked with Dr. Shaw and actually Grafton a number of times through the transition. So if there was anything outside of the letter.
Would the original approval and scoring of Dr. Shaw be consistent, whether it was Devil's Lake or Grafton?
Yeah, it would.
Ranking?
Yeah, those areas are still areas of need in our rural communities, definitely.
And Grafton is willing to participate on their end?
Yes.
And then as a reminder, historically, we've had a tendency to allow these changes so long as it's still serving the original intent and the receiving hospital was also willing to participate.
Yes, we have, but we've wanted to always make sure, again, if they were in a rural community, they went to a rural. If Dr. Shaw would have gone to Fargo or Grand Forks, no, we would not have.
Okay. Other questions?
Do you need a motion?
Yes.
I move to make the.
Go ahead.
Nope, you finish. I'll just get your second.
Second.
So move to
I move
approve
that we
the
approve
termination
the
and the adjustment.
Okay. Seconded by Dr. Wolf.
Yes.
Any further discussion? Pamela, would you please call the roll?
Birch,
Yes.
Russo,
Yes.
Dietzman,
Yes.
Fedorchak, Lanoy, Poole,
Yes.
Roars,
Yes.
Sailor,
Yes.
and Wolf.
Yes.
7
Motion.
ayes, 0 nays, and 2 absent not voting.
All right. Would you like to continue, Bobby?
Yes. The other two documents are just information. The first one, the fact sheet, is the one that was created the first time before the 2018 legislative session, where I just had general information for the legislators on that first page. And then on the second page, an update on numbers of how many have applied and how many were awarded. And I was able to add the 2020 numbers since those contracts were in place as of July, as well as check into the retention from the beginning of the program to update those numbers at the bottom. So that is our second time around doing that. And I just wanted to let you know what I wanted to point out on this one was the physicians, when we did this in 2018, the retention numbers were 71% then. Now they're 66. The dentists were 86% retained. Now they're 87. So they have gone up 1%. Our physician assistants, they were 79% in 2018. So now they're 71. And our nurse practitioners were 87%. And they are 67% now. So I know this is the second time around for some of you, but some of you are new to the Health Council, so it's the first time. you're seeing this fact sheet. Are there any questions? And my intent when that was created in 2018 was to do that before each legislative session. As you can imagine, for the retention numbers, we're having to call check on every single person who's ever been in the program from the beginning who's still there. So definitely every 2 years is enough for that project.
So Bobby, can I ask a question just based on what you just said there? The if they've ever been in the program, are you breaking out like if they're leaving at what point so that we kind of know like this program, we retain them through, you know, the full time, the commitment that was required, but then, you know, people, you know, 10% of them left in the first 2 years post program and then 5 years and 10 years. And, you know, just so we know when is that risk point?
Well, because it wasn't done before me, that's what I wanted to do in 2018, but that was really hard to get because clinics couldn't tell me when people left. So that was my original intent. So what I ended up doing was taking who completed and then are they still there or not? So that's why I say anybody who completed the entire contract, well, now it's 5 years, that has changed over the years. And then I've just said, are they there today?
Is there a way for us to then just say going forward, let's try and figure out where our risk point is with these programs to know that yes, the success rate of retaining them for the contract plus X amount is, you know, I think that would be helpful for employers as they decide to get into this as well is what can I expect on average this program to help me? Because if they're saying, okay, well, internally, I keep someone for 10 years normally on average anyway, with or without this program, and this now puts them at 7 years. Is that worth the money up front? I think there's some opportunities for us to at least going forward, start collecting data in that way.
And I actually have collected that for the 4 years that I've been with the program. So moving forward, we certainly can.
Awesome. Thank you.
Yep.
Good point, Kristen. Thank you.
Oh, and again, I'm sorry, and I should have pointed out because somebody knew behavioral health has not been around long enough to add to the retention chart yet. So nobody has finished a 5-year contract. So sorry, I forgot to mention that. Okay. Any other questions on this one? And then Pamela, if Dr. Stahl had all of these documents, he at least could get a quick picture of the program. I'm not sure what was sent. So he'd know what we're referring to. Page 1, Dr. Stahl just gives a really quick summary of the loan repayment program. It's not all the details, but.
And historically, Bobby has also turned out some maps that kind of show where these providers are located. And I think that'd be very valuable to Dr. Stahl too, to see how it's effectively being seeded into those rural communities or the major hospitals that serve a regional need to those communities.
Yeah, great idea. I'll send the maps too. So then on the second one is, again, this is probably just the second time around showing this. This is the outside vendor so that we've contracted with before my time. I actually would like to start moving away from this vendor because we can't change what we're asked and we do not get to modify the questions, but it still is really good information and it has been collected since 2013. I did just take a snapshot of the National Health Service Corps, the federal program, compared to our state programs in the last year, just to give you an idea. So hopefully you took the time to look at it. I wasn't going to go through it because it's self-explanatory, but I thought it was really good information. And in the 4 years I have looked at it, it's very similar every year that salary is not job satisfaction. They do not feel they're paid enough in North Dakota, but definitely there's job satisfaction. So that's nice to see that they're pleased with their work. But did anything else jump out to anyone, or do you have any questions? Did you feel it was valuable at all? Or as I'm thinking of moving into designing my own survey, is there anything that you didn't see here that you'd like added to?
Questions? No, it's a fair amount to digest, but
All right, well, that's all I had today. I have to have a few short months with you guys, so our meetings.
you need a break every now and then. All right, then if there's nothing else for Bobby, then we'll go to Dr. Stahl for the state health officer updates.
Thanks, Dwayne. So what I'm going to do is I'm going to kind of break down the process and the transition, and then I'm going to talk about the here and now related issue items and kind of where things will sit as we go forward. Through the transition, as I started on June 1 as the interim state health officer, one of the first pieces that we had made was ability to allow in order to make the department more operational, which traditionally was maybe not so much some of the asks in the past, primarily being a data resource with policy advisement, being more of a traditional aspect, but also licensing of facilities, et cetera. A lot of that stuff has changed with the pandemic, as I'm sure everybody's aware of, with the dissemination to a state-led response rather than having a national response, which has resulted in the Department of Health having to make some significant changes in how we respond to things. So with the COVID-19 pandemic response, initially in March, the Unified Command had it. That was subsequently disseminated. Based upon how this pandemic goes, it's possible that there would be a series of reactivations with the Unified Command, which then would mean that the Department of Health would be run under the UC commanders. That will possibly change here in the near future, depending upon how this pandemic process actually goes. The state lab was recently taken out and moved under its own organization from a section lead under Dr. Mason. That was felt needed because of what the lab has been asked to do. Traditionally, the state lab had the capability of running about 195 PCR tests a day. That has subsequently increased significantly. Our greatest numbers have been in the mid 6,000s. Recently, they've been anywhere between 4,000 and 6,000. I believe today we were just over 5,000 on our tests for PCR tests daily, being the current gold standard for testing. So with that, the lab has had to grow. It's had to purchase machines to be able to do so. We do run many of the tests throughout the state, regardless of where they come from. It's been our policy so far that we will run whatever test is sent to us in order to achieve the public health good in this particular pandemic response. We've had temporary technicians that we've brought on. We've had some difficulty retaining those temporary technicians to run our samples. A lot of them have jobs that are spoken to with other hospitals. In the absence of having an FTE for these techs, we've just not been able to retain any of the temp employees. With that has created some challenges. Fortunately, we have several members in the National Guard who are well-trained MLSs and MLTs that have been able to fill those gaps for us in times of need. But I would state that we are relying heavily upon the National Guard to essentially do any of the response that we're asked to do, particularly within the lab. So we are looking at ways that we can do the same amount of work with being able to give our techs breaks, vacation, that sort of thing that they've not been able to do so far. We're looking at new devices and new machines to be able to achieve that. My big concern looking into the fall is going to be what happens when influenza becomes concomitant with COVID-19, and we have to really answer to some other issues that are really unknowns at this point. We're building this plane as we fly it, so to speak. But we're trying to do the best to mitigate any of the kind of consequences that would be there. So as we look at automated versions of testing, we're getting quotes from various companies to see how we can best do this efficiently, with all the asks that we're also having to serve from tests being sent in from elsewhere. So that's kind of the lab standpoint of it. We did shift and create a chief of staff position under Dirk Wilkie, who is monitoring a lot of the day-to-day operations of the traditional aspect of the Department of Health, while it is that I have to respond significantly to the day-to-day operations of a pandemic response within the state. And that, by and large, change has allowed me to be responsive and to be able to do those things a little bit more than in the past. It's a fluid org chart, I would say. We're making adjustments as needed, as the demands placed upon us are requiring us to make those changes as well. So nothing is necessarily set in stone, but we're making those changes. Our plan for the lab in the future is to develop a better collaboration between our university systems and the Department of Health. One thing that we know is that when we have lab tests or samples sent from Grand Forks, North Dakota, or Pembina, there is a commute time that's involved in that. It does take a significant, it takes 6 or 8 hours for it to get here. If the constituent sees that they have their test done at 7 o'clock in the morning, but it might not be logged into our lab until the following morning because of the labs or the test being done until late in the day. Then it getting on a truck and being delivered to Bismarck. We're trying to cut down that time, in other words, by being able to have some regional sites set up between Fargo, Grand Forks, for example, and wherever other places that we're able to establish extension labs, for lack of a better term. So we're working on really developing a collaboration effort with our university systems to be able to make this better and more efficient and more responsive for citizens of North Dakota. I'll speak about the K-12 restart component real quick. We are working closely with Department of Public Instruction to be able to have a resource pool within the Department of Health that will work closely with DPI as well as the local public school districts to have resources for when the school restart does occur, so that we're able to have a responsive mechanism and answer the questions that we have experienced in the past, analogous to long-term care. But then we'll be able to have some resources when people aren't able to necessarily have their resources at the local level, understanding the fact that there is significant variation in how this virus has spread throughout the state. There are counties that are relatively unaffected in comparison to other counties, which that prevalence in and of itself will affect the school restart plan. So we're working with being a resource pool for those local public health units and the respective superintendents and principals of those facilities. Additionally, the North Dakota University System restart is another concern that we have. Essentially, we know that anytime we bring people into a congregate setting of any kind, the risk of spread is higher, significantly higher. That's something that we're also looking at. We know that if we can test and contact trace, we have better outcomes in that regard. With the CARES 19 app that we've developed, there's been a lot of buy-in from younger generations in using that app. It's helped us do some of the contact tracing in that regard. We're hoping that that might help some as well. So there's been a lot of changes as been asked and required of us in this short interim. We're doing the best we can to make and be responsive as needed. It's, again, been a day-to-day learning process for us. And every day I come in, something new or something different is occurring. And I think that kind of sums up the last 60 plus some odd days that I've had here so far. But I mean, if there's any questions, I'd be happy to answer those as well. I know there are questions, so.
Doing a great job there, Dr. Stahl, and I commend you and everybody else in the health department. When school opens now, is there going to be regular testing of the teachers, of the student body, or do you think there'll be any of that, or we're just going to kind of keep people under observation?
Right. So looking at the recommendations, for example, for students from the American Academy of Pediatrics, they recommend testing symptomatic students in the K-12 level. My big concern is it's the teachers, it's the individuals that are, when we look at the data, for example, several reports have come out recently, peer-reviewed journal articles that state that children carry a higher viral load, but they're asymptomatic, which means they're more likely to spread it. When it comes to adults, the teachers, the janitors, those people that are in these facilities regularly, I suspect that they're going to be the ones that develop symptoms, or their parents of these students that will develop symptoms. My position is that if a faculty and staff of a particular school want to get tested, we've tried to develop sites throughout the state of North Dakota so that there's at least a minimal commute time to get these tests if they're not in a major municipality. And I would encourage that to be the case. I do follow the American Academy of Pediatrics recommendations that symptomatic students should be tested, but testing all students is probably not realistic based upon our current capacity, considering the fact that it's about 120,000 students, I think, statewide in North Dakota. We're not quite there yet in that capability. So that goes back to the best mechanism to do this is the risk mitigation of the COVID-19 etiquette. Wearing a mask if you're able to, washing your hands frequently, and socially distancing as much as possible.
So, Dr. Stahl, wearing the mask when you're able to, I think I heard you make a statement in the press releases that people with breathing issues might be somewhat forgiven for not wearing them. I thought I read a release by the American Lung Association and like 4 or 5 other like pulmonary organizations, doctor organizations, that basically came out and said that O2 levels are not affected by the wearing of the mask, and that most people should be able to, unless there are like some really specific, significant instances as to why it would preclude them from doing so. And is that accurate?
Right. So what I would state is that for me to project that to the public, I also need to take into consideration the individuals that are on oxygen that have a low, what we refer to as a forced expiratory volume, FEV1 that's significantly diminished, the advanced comorbidities of COPD. I don't want people to interpret what I say as being that those people should also wear a mask, because that could be significantly debilitating for them or cause significant self-harm by putting a mask on themselves.
Okay. That makes a lot more sense than the way that I had interpreted the statement. So thank you.
Masks are a very contentious issue in North Dakota. I've received a lot of emails and calls about, just since I've had that press conference. The data is there, and it's getting better every day. That masks do help mitigate the spread of this. And in fact, it was recently reported that neck gaiters, which is generally a single layer piece of cloth, actually increases the spread of the virus rather than it does limit it, which we're also going to seek to message to. I don't know how much hate mail I will receive from that, but it's possible that I'll receive some.
I was just about to say something about the fan mail.
We'll get you a giant ad hominem T-shirt or something. So shoot the messenger because of the factual message.
Right. I think that's the point, is that as I'm trying to speak more to the evidence of things, and that's the goal, that we back it up with evidence.
So just out of curiosity, when you just said that neck gaiter, are you saying increases versus not wearing anything, or versus wearing a mask?
Yeah, so the results of it, and I can send the link to this, what they found is that like the large droplets, when wearing a single layer neck gaiter mask, it atomizes those droplets and makes them aerosolize so that they efficiently spread throughout a contained environment. So it actually can promote spread of the virus.
Interesting.
So I guess I'll follow up then with a question over the budgetary issues. I know that we've received some federal assistance as a state. We're in a little bit of a budgetary crisis as it is. We're coming into a legislative session. You've gone from 205 FTEs to 500 staff, including your original FTE allotment under an emergency clause. Where are we? Where do you see this going? Is there anything we should be thinking about coming into the legislative session or into the budget cycle? Maybe that's a Brenda question for next time, but.
Yeah, I think I would speak to certain asks that I have that I feel kind of passionate about, and that's that the Department of Health we've had to work really closely with the local public health units, and that has really actually that should be a position I feel that we would have within the Department of Health, so that we can have some data sharing mechanisms. We collect the data at the Department of Health, but then we have, if they don't ask for it, there's no sharing of that information really, and that really needs to be improved upon, I feel, because the operational level of public health is really happening at these county levels. They're the ones providing the immunizations by and large. We do some of it, but there has to be a better way that we can achieve that goal. And I really think that having a person dedicated from the Department of Health, or maybe several to do that, would really do wonders for the state of North Dakota.
So
additionally, go ahead.
This would be on top of the public health position that Mr. Weidrich has that helps develop the funding mechanisms and pass through for the public health units. This would then be in addition to that, that's more a data focus.
Correct. Yep. It'd be similar to having, regional EPIs, but it would be also within our analytic department that comprises and takes in all of the information that we have and then kind of disseminates it, so to speak.
Okay.
The additional aspect that I think would be important is we have learned that we're short on techs to run our labs on a regular basis. I have concerns about, I'm very fortunate that we've got such a wonderful lab that works so hard and has done such a wonderful job. I think about the big picture, the 60-day, 90-day, 120-day, process, and, keeping individuals happy, healthy, and productive in their day-to-day work. And that's something that we need to do a better job on, I think, in making sure that we recruit the people to help get us through this whole process. So I worry about the FTE equivalents in the lab.
Well, and I think I asked this question at our last meeting when Kirby gave us an update, but are there some opportunities as we move forward to partner with schools to say, how can we get some quicker throughput of students with the right credentials to be able to meet these needs? Because I don't think, even as we kind of transition out of heightened pandemic mode, there's still going to be this a new level of testing that was never there before. So I think we're not going to go back down to how we used to be. And so what are our opportunities to really partner with some of the local area schools and say, is there, like, I got my bachelor's degree in nursing in 12 months. So what kind of opportunities are there to create an accelerated program for those specialized skill sets that we're going to need going forward?
Right, exactly. And I think what I think we really need to do, and I've thought about this, is partnering with our local technical colleges throughout the state and our university systems to be able to have a track mechanism, but also maybe, for lack of a better term, almost like a fellowship within the Department of Health so that they can come in and see what the Department of Health has to offer, what our positions are, what all those things are, our equipment, our labs, or even looking at it from a bigger picture, epidemiologists and master MPH students, being able to offer them a position in the Department of Health as kind of like an internship or a fellowship would be really beneficial to help them see what it is that we have to offer here so that we can retain our graduates and keep the best of the brightest. That's something that I would really like to work towards.
And I think partnering with Job Service North Dakota as they're working with all the unemployment insurance, and I know there's some work requirements and that kind of stuff, but how do we say, is there an opportunity to really highlight some of the opportunities for people to upskill into a new type of role?
Dr. Stahl, the MLS sort of ACT deviation in clinical lab technologist certification sorts of things. It's the military has a standard, and then the public tends to have a different, slightly higher standard for it. Is that an impediment to this? And then my follow-up to that is, if the universities start having issues with the ability to offer classes, is there an opportunity to reach out to those students with that fellowship idea that haven't yet completed their program, but have enough technical skills to be trained in that if it becomes basically a semester off or a year off, do we have a surge capacity opportunity there?
Those are excellent points. I do not know the standardization difference between the military versus what, for lack of a better term, the civilian counterpart would be. I'd have to look into that. But you bring up an excellent point about being able to have a surge component if there was, for example, a rotation that could be done off campus at our state lab under the guidance of our senior techs, that kind of thing. But that's a really good point. I like that.
My dad used to teach at Shepherd Air Force Base, their lab technology program.
I'll write down the surge question about a rotation aspect and see what Dr. Mason thinks about that.
Any other questions for Dr. Stahl?
The only other comment that I would have too, Dwayne, when we're talking about, fellowships or maybe field placements and working with the local public health units, are there some maybe opportunities to offer a field placement in those regions as well? Just to kind of keep that open.
Yeah, I don't think I would limit it to saying they have to be in Bismarck. That would be ridiculous to say that it's going to be limited to that. The collaboration or the individual preference might, it might be better that they be at a field site, for lack of a better term.
Okay, good.
Yeah, and I don't envy you the need to fill these staffing issues with it being something that, as you look further down the road, saying a year from now, 2 years from now, you can't justify the FTEs, yet still trying to fill those positions now. Are there opportunities or ways that you can look at other potential positions where where they could serve a role temporarily in the lab, but then move to other positions later?
Yeah, that's a good point. I don't think that there's any reason why we would stovepipe somebody into one, position if their capabilities are stronger for or could be moved and used elsewhere. I think the one thing that we've learned through the pandemic is that we've all had to make adjustments and changes to no matter what position or department as to which we serve, in order to meet the objectives. And I think that that's a real key component, is the understanding that we need to be flexible, both with what we do on a day-to-day basis, but also what our asks are.
Did you have any other major points in the budgetary issues that you wanted to bring up?
The one question I think that we'll also have to speak to is going to be testing and its cost. Right now, we have it through federal funding that has helped us kind of do this testing so far. The tests are not cheap. That's one thing that we're going to have to be prepared for. The hope for the vaccine, I think, is still very much so in that realm of hope. It is in phase 3 clinical trials. Multiple ones are mRNA vaccines. I was actually just looking at the list last night. I think 9 different companies now that have advanced in the clinical trial process and have received federal funding for pursuing that. With that also comes the fact of where we're going to have to distribute this vaccine, the ethical components of it, who gets it first, that sort of thing, and where North Dakota would fall in that dissemination list as well. So all things that we have to speak about, meaning that I don't think that testing is going to go away. I do have concerns about the acceptance rate for this vaccine. North Dakota has 2 components that make vaccination challenging. That is the religious exemption and the philosophical exemption. So that results in our immunization levels being lower in a lot of instances. And then when we have something named Operation Warp Speed, where it sounds like something was absolutely rushed through, I think it makes things a little bit more scary for people to get the immunization. So we've got an uphill battle with this, with the vaccination component. And the way that I would message that further on is saying that because of that, testing is going to have to be still part of the regular process as we move forward for at least probably the next 6 to 12 months.
Good point. So, is there anything further you'd like to ask Dr. Stahl?
Again, I'd just like to say Dr. Stahl does a great job of explaining things. I'd like to see him on TV more, maybe some public service announcements or something like that, where he has a good presentation there, and maybe we need to support doing some of that more than we have in the past.
I would state that part of my emergency commission request was money to use towards a public-facing campaign to be able to message the important things about COVID etiquette, about what the Department of Health is here to help with, that sort of thing. And hopefully I believe it actually we get it today, but then we'll be able to make some of those changes. And that's kind of part of the overall mission in the short term as well.
Well, we North Dakotans are very special people. We like to hear from other North Dakotans too. So if you can do something like that, I'd like it.
Absolutely.
Dr. Stahl, Mary Van Sickle at the Community Access Television was producing a Public Health North Dakota piece that actually had really good saturation in the communities. That as you feel comfortable with information that hopefully doesn't have a moving target to it, that might be an opportunity to do one of those sessions. So
I would look forward to that.
So your PIO would probably have to reach out to Mary Van Sickle to arrange that.
Yeah, I can ask Nicole to do that.
Any other business before the council, other members? Hearing none, is there a motion to adjourn?
So moved.
I move we adjourn.
All right. We have movement to adjourn. We'll consider this meeting closed.
Thank you very much for your time today, and it was nice to meet you all.
You as well.
Very much.
Thank you, Dr. Stahl. Appreciate your efforts.
Thank you.
Thank you.